Welcome to Theories of Addictions. This is week 4, and I will be covering the behavioral model. As always, there are 2 lectures in this week. This first lecture will be on the general behavioral model. Lecture 2 will be on the application of that model to addiction. So let's jump into kind of a general introduction to the behavioral model, especially if it's been a while since you've studied it. And I'm not going to cover all of the aspects, but generally those that may be relevant to addictions that we will amplify on in lecture 2. The primary assumption for the behavioral model is that maladaptive behaviors can change without insight into their underlying causes. And so this is in the backdrop of this is the psychoanalytic or psychodynamic theories, which were insight theories that really wanted to, their assumption was that disturbance was caused by events in the past, and so they needed to kind of do a psychological dig or an archaeological dig into the past so that the client would have insight into those unfortunate events that shaped someone's cognitions and emotions and behaviors, etc. This model is radically different. It does not doesn't do this kind of archaeological dig in the past, but it's going to look at the symptoms of the client when they come in. And the assumption here is that those behavioral symptoms should be just taken at face value and should not be viewed as symptoms of some deeper problem. So the model is based largely upon learning theory and include 2 kinds of really important issues. One coming from Skinner and his work at Indiana University and Harvard, in which he came up with operant conditioning, that behavior is shaped by its consequences, that the consequences of the behavior will shape the behavior. If an individual receives positive reinforcement, then for a particular behavior, then that behavior is going to increase. If, however, the individual receives punishment, then the associated behavior will decrease. However, there's another possible one. If the individual or the client receives no response at all, then the behavior will be extinguished, that over time it will be eliminated or just dissipated. Pavlov earlier had developed classical conditioning, in which he had behavior was shaped by being coupled with or uncoupled with anxiety-provoking stimuli. So you probably remember from introductory psychology that Pavlov had dogs, and his dogs were taught to salivate at the sound of a bell. Once that bell was associated with the dog receiving some meat to eat. A person can be conditioned to experience fear in actually neutral situations where those neutral situations have come to be associated with anxiety. So that dynamic we will look at when we get to addictions, because that is really important in understanding how addictions come about and what maintains them. So we can uncouple the anxiety from the situation, and then not only will the anxiety go away, but the behavior associated with anxiety. And the associated generally with anxiety is avoidance. So if we uncouple the anxiety from the situation, then the anxiety won't be there, but also we will not see the client engage in avoidance behavior. So let's look at what the behavioral theory really focuses on. And chief among those is current problems. The focus when a client comes in is on their current problems and the factors that influence them, not historical determinants. So we're going to look at current problems and the factors that impinge upon those current problems without going back and looking at historical determinants. So there's going to be a focus on overt behavior, and the goal will to get overt behavioral change, and these changes are the way that the therapy will be evaluated. We know that the behavioral therapy is going well if there is a change in the overt behavior that the client wanted to change. To do this, the therapist, in collaboration with the client, needs to develop very clear, concrete, specific, and objective goals. Not vague. Not like, I want to feel better, because that would be so vague as to say nothing. It needs to be very objective, measurable behavior that we want to achieve. The treatment is going to emphasize teaching clients to a large degree. It's going to be emphasizing how to teach clients to manage their own behavior so that they better reach their desired goals in life without the problematical symptoms. And remember, those desired goals in life can be personal goals, professional goals, interpersonal goals, educational, occupational, even spiritual goals. So we're going to look at behaviors associated with them and how to change them. The procedures in the treatment will be adjusted to the unique needs of the client. And that is really, really important, because many people think that sometimes that therapy, that you're just using general methods, but certainly not in behavioralism. Behaviorism is going to be very, very specific to the client. They will develop interventions that are very specific to the client and the client's problems and the conditions that are associated with those. The aspects of the therapeutic process, what goes on in the therapy, are really, really straightforward. The goal is to create new conditions for learning. Remember, this is a learning theory. So the belief is that those maladaptive behaviors were learned. They just didn't pop out of thin air. And so if they can be learned, they can be unlearned, and new behaviors can be learned and put in their place. So the goal will be to create new learning conditions, okay? And then once we have that set up, then there's going to be this ongoing process of assessment and treatment. Now, many people believe, and some therapists even believe, that we should assess first and then treat. That is not the behavioral model. Assessment is an ongoing process and treatment is an ongoing process. And so we're assessing while we're treating, we're assessing whether that is helping that client reach their goals. So it's not as though there's an assessment phase and then a treatment phase. They're ongoing and they're coterminous, okay? And some individuals have stated, and some researchers have stated, that there are 6 steps in this process. And I don't want you to think that this is a rigid model, but generally we have these, it can be broken down into these 6 steps. One, of course, we need to identify the maladaptive behavior, the problematical behavior that the client is bringing into the therapy. And then we need to determine what assets or strengths the client has so that we can build upon those within the therapy. Maybe they have some cognitive assets, maybe some emotional assets, maybe they have family assets, etc., or they live in generally good environment. So we want to do a full assessment of those clients' assets and strengths. Then, of course, we need to gather the information on the context, the learning context, the life context in which the maladaptive behavior occurs. So, when we look at that text, that context, we're looking at what are the antecedents of the maladaptive behavior and what are the consequences of that maladaptive behavior. So we never look at the behavior without looking at the context of that behavior, because all of the context is relevant to the production and the maintenance of that maladaptive behavior. Then we can, once that is we have a grasp of that, and that's going to be an ongoing process. It's not like that's going to finish, but we need some provisional information to get going. Then we set up a strategy to measure each of the problematical behaviors. For example, we're going to look at how frequently does that behavior occur, and from that we have a baseline so that we know whether, again, the therapy is going well. Because if we see the frequency of the maladaptive behavior decrease, then the therapy we know we have some objective measure that the therapy is going well. So then we're going to look at the reinforcers for the behavior, right? So those reinforcers of the behavior, and I'll mention some of those, will then be surveyed, and those will include people. So people in the client's environment may serve as reinforcers. Some people in the environment may not serve as reinforcers and may serve as punishers, okay? So we need to assess how individuals within that client's environment are functioning as reinforcers. Are there certain activities that are occurring in the environment that serve as reinforcers, or even actually things? Well, the things that we will be talking about in addiction will be the drugs themselves, as well as some other factors. So knowing those, the people and the activities and the things that serve as reinforcers, those can help provide motivation for treatment, and then maintenance of the progress that is made subsequent to treatment. So once that's done, we kind of come to the last step that needs to be accomplished, and that is the formulation of treatment goals. What will be those very specific goals? And we've already talked that they need to be very specific, concrete, measurable, and observable. And so we're going to look at the goals and for the client, right? And so this is a collaborative process. And those goals can be in many different domains of the client. The goals may be affective. Affective would mean emotions. Does the client want a change in emotions? Maybe they are experiencing depression and they want the elimination of that depression or anxiety or whatever, anger. That may be cognitive. There are certain thoughts that may be maladaptive and need to be changed. Behaviors, of course, we're going to look at that. And then also interpersonal behaviors that may need to be investigated. Okay, so that gives a quick overview, much more detail. And if you need more detail, I really encourage you to go back to your intro psychology that you booked, that text or whatever that you had in your undergrad studies, or just take a look at one, go to the library or whatever, and just brush up on the behavioral model. But that's going to give you a little bit of information that we'll be using in the second lecture. But I want to look at some common misunderstandings of the behavioral model, because there are numerous misunderstandings. I hear them all the time, and they're utterly erroneous, and it would be helpful to correct those, because many people just often may not embrace behavioral, maybe not the whole model, but behavioral interventions because they have bought in or they've heard these unsubstantiated criticisms. So one is the belief that behavioral therapy focuses just on removing the negative symptoms, and that once this is done, that a new symptom is just going to pop up in its place. Why? Because the assumption here is that you haven't gotten to the deeper or core issue. Well, one, that assumes that there is a deeper core issue, and that's an empirical question, and research doesn't substantiate that there is this deep core issue. I mean, learning theory pretty well can describe what's going on here. But even if we assume that there was, then this is an erroneous misconception about, because in reality, behavioral theory focuses on not only removing the maladaptive behavior, but replacing it with more adaptive behavior. And if a person has more adaptive behavior, then there's no need to assume that there's this void. You know, if we just remove the maladaptive behavior, so a new maladaptive behavior is going to come in its place. Not necessarily, right? Because we've made the behaviorism will have removed the maladaptive behavior and put in its place an adaptive behavior that will help the client function in that environment vis-a-vis the goals of the client, the desired goals of the client. Two, research simply shows that there is no substitution of symptoms if we eliminate one symptom, right? Research doesn't support that at all. So that pretty well, I hope, lays to rest that misconception. Another one is that behavioral theory is about the therapist doing all the work and telling the client what to do. Well, again, that's a huge misnomer. Or that the therapist is going to impose the therapeutic goals upon the client. Not true at all. Behaviorism and behavioral theory is largely a collaborative venture with therapist and client working together as partners to help the client reach their desired goals in life. And in fact, the selecting and defining of the therapy goals, I'll just show how they're a collaborative venture. Sure, the therapist does have the responsibility to explain the purpose of the goals that they collaboratively come up with. They're going to be showing how that may change the maladaptive behavior. That is the therapist's responsibility to articulate that. But the client will be choosing the positive changes that she or he desires as a result of the therapy, right? So it's not like the therapist says, this is what you need to work on, and this is the emotional behavior you need to have. That's not it. This is a collaborative venture with the client. And then the client and the therapist will collaboratively determine whether those goals are realistic. And that's tremendously important, because often, a client may come in and they may be experiencing like deep depression, and then they say their goal is to experience happiness. Well, that may be a long-range goal, but it's not realistic in the short range. And so if we embrace this unrealistic goal that in a short amount of time the client is going to be unhappy, then they may be frustrated with the therapy, give up on the therapy, whatever. So it's really important that we have realistic goals that can actually be accomplished, and collaboratively they will, the client and the therapist will discuss that. So they'll discuss the possible advantages and disadvantages. Therapy has some great advantages, but there are also disadvantages, because sometimes in the discussion of issues that clients may have been pushing away, then some emotional pain may come up because they're facing things that they wanted to avoid, right? Remember, with anxiety, we have avoidance. Well, if we're trying to address the anxiety, then and the client is not avoiding it, then the anxiety may come up. Well, that can be painful at times, so we need to discuss the potential advantages and disadvantages, and that therapy may involve discomfort, emotional discomfort, right? Another misconception is that behavioral theory focuses on the scientific processes of change and downplays the therapeutic relationship. Let's get very clear. Behaviorism is scientifically based. That's absolutely the truth. But simply because something is scientifically based and it's been thoroughly researched does not mean that the therapist who embraces scientific research is going to be anything but a warm human being toward the client. Both of those can be accomplished. So we want to be very aware of science and what tends to work and has generally positive outcomes for clients. But we also want to have a good therapeutic alliance, a relationship with the client. Okay, and there's a lot of research that has gone into what factors contribute to a good therapeutic alliance. Too often we can be very vague and say, oh, what we need is a good therapeutic alliance. Okay, fine, but what does that mean? What are the factors that contribute to that? And behaviorism, and even more recently, we've had great advancements in research about what are the real factors that contribute to a solid therapeutic relationship or a solid therapeutic alliance between the therapist and the client. And of course, behaviorism should never be done rigidly because remember, you're developing interventions that are very specific to this client with their problem and their environmental influencing factors, okay? And those are unique, and so the therapy will be unique to the client. What we do know is that the client's positive expectation of the outcome does contribute to the outcome. So many times knowing that this therapy has been, rigorously scientifically tested does help the client believe in a positive outcome, okay? And so that's one very important factor. Factors such as empathy and authenticity and warmth of the therapist and acceptance on the part of the therapist of the client are necessary, but research shows they are necessary components, but they are not sufficient. Of course, we need all those aspects of the therapist toward the client as humans, but we also need competency in using interventions that actually work with that client in those environments. There's no way around that. So the truth is that in behaviorism, the therapist must have a high level of skills. Excuse me. Those two go together. Good personal relationship, good factors there, and some competency. The other one is, let's shift then to look at what are some of the techniques that would be used in behavioral therapy, okay? And again, we may get more specific on that in lecture 2. But the general techniques of all behavioral therapy include, one, relaxation training. It's very, very common for a behaviorist to teach clients how to relax, and they can learn progressive muscle relaxation. Wonderful, especially for individuals with anxiety or fear, those kinds of things. And they'll just learn how to just systematically go through their body and tighten muscles and relax the muscles and notice the difference. And so it's a sequential treatment that has some really good outcomes. And then also abdominal breathing, diaphragmatic breathing can be really helpful as a relaxation tool. It's pretty simple to do. You put one hand on the stomach, one hand on the chest, and when you breathe, you want to move the hand that's on the stomach, not the hand that's on the chest, because when we're anxious or fearful, we tend to breathe really fast and up here. So we want to slow that down and do abdominal breathing from there. And so doing that for a few seconds can really help kind of relax an individual. It's not going to take all the anxiety away, but we're kind of coming up with a tool chest in behaviorism of things to do to help individuals. Another technique is what's called systematic desensitization. The assumption here is that the anxiety response is learned and it can be unlearned, or it can be disrupted by substituting an activity that is antagonistic to anxiety, so more relaxation, right? So again, this is often used with anxiety and the associated behavior with anxiety. And remember, the associated behavior of anxiety tends to be avoidance. So one of the things that they do is when they're looking at systematic desensitization is a behavioral analysis of the stimuli that tend to evoke the anxiety. So maybe, let's say for me, the stimulus would be to see a snake. I have a snake phobia, right? And live on a lake in the southern part of the United States, and so I hear there are snakes down there, so I avoid the lake. Although it would be nice to be able to go there, but I haven't done treatment for this, and so I still have my snake phobia here, and so because I have the anxiety, then I avoid that stimulus, that going down to the lake. So they would look at a behavioral analysis, and they might want to say, when you look at a picture of a snake, does that evoke anxiety? Okay, when you think about a snake, does that evoke anxiety? So they're doing a thorough behavioral analysis of that. And then what they do is that they develop a hierarchy, right? And at the top of the hierarchy would be those things that, for me, would actually cause the most anxiety related to snakes. And then and then we sequentially go down that hierarchy, and at the bottom would be those that would be less anxiety provoking. And we call that, this method was developed by a theorist called Volpe, and he called it SUDS, the subjective units of discomfort. And so we get a hierarchy of these subjective units of discomfort because they're specific to the client. Not everybody's going to have the same hierarchies. They're not going to have the same SUDS scale, okay? And then we teach, and once we have that, then we're going to teach relaxation. Not only teach it, but we're going to actually practice it in the session. So teach and practice the relaxation responses. And we just, with imagined situations, and then work our way all the way up to the most anxiety provoking. But we sequentially go up that, knowing that for each level we're going to be using the relaxation technique. So we progress up the SUDS hierarchy. Another technique that is, the goal would be the same as progressive muscle relaxation, but the process is generally different. The process is called, the technique is called flooding. And here you don't begin with a SUD scale, you go right to the top. So you would, for example, someone were working with me, they might hand me a snake. Well, that would be flooding because my anxiety would just shoot, right to the top. I'd be holding a snake. Flooding works for a number of people, but it is emotionally quite uncomfortable, right? So many clients won't want to, to do flooding. Some will, and if they do, it can be really quite powerful and helpful for a good number of clients. So flooding there's no progressive SUDS. You just move to the top and go with that. And there's a lot of preparation with the client and learning how to relax prior to doing that. You don't just, second session, if I went in second session, they're not going to hand me a big snake. Okay, well, I certainly hope they wouldn't, but that is not how flooding works. There's lots of preparation with the client to do that. Another technique is what's called modeling, and we are really indebted to an absolutely fantastic psychologist by the name of Bandura, who studied modeling and really allowed us to learn the importance of modeling. And excuse me, there are 3 effects of modeling. So modeling is that there's an individual who models for someone else the behavior, the desired behavior that the client would want, okay? And so one effect is that the client would get new responses and skills. So they would watch what the model does, the therapist, and then they pick that up. 2, they would learn the inhibition of the fear response. So they've learned the fear response, but as the model, the therapist, let's say, who's working with me would be holding the snake perhaps, and I notice that they're not fearful of the snake. So not only would they get me some skills, but they would also model for not having the fear response, the anxiety response, okay? So the model performs an inhibited fear response with positive consequences. So that's really important. And then there's what's called a facilitative response. The model provides cues for the other to what to do. And the models, let's just look at what can serve as a model. Well, sometimes they're live models. So in therapy, if the therapist is demonstrating that, or let's say the therapist sends someone to, let's say to me, sends someone who is experienced with handling snakes, and that snake handler would serve as the model. So that would be live modeling. There's also what's called symbolic modeling. So for example, we might have the individual watch a movie where someone is dealing with snakes, etc. Okay? And then there could be multiple models. So for example, let's say there's group therapy and we see individuals who have a similar symptom or problem, and they're all working to overcome that. So there would be multiple models for that. Other things that behavioral therapy works on is assertiveness training. So many individuals may not be assertive, and we will see how this is really important when it comes to treatment of addictions. May not be assertive in not taking something or not doing something. So we put assertiveness on like a scale, so up from aggressive behavior, which is really attack, inappropriate, or utterly passive, where we don't speak up, we don't assert ourselves. And so they would learn how not to be aggressive and how not to be passive, but how to be appropriately assertive, and that would be different in each different context, right? So the client would learn how to make that appropriate decision. And the other one is self-management, is that we teach the client the skills to manage their symptoms, and we often call those coping skills. There are many other techniques that behavioral therapy does, but these are some of the ones that are really important within that therapy. So thank you, and we will go and look now into this week lecture 2, in which we will use the application of this very important behavioral model to substance use disorders and general addictions. Okay, thank you and have a good day.
The Masters of Arts in Addictions Counseling at Columbia International University prepares graduates to be successful in an occupation that is experiencing job growth at a tremendous rate. This program integrates faith with evidence-based knowledge and practice in diagnosing and treating addictive disorders from substance abuse to behavioral addictions. CIU's Master of Arts in Addictions Counseling is the only academic program within the U.S. to offer certificates in addictions counseling through the Albert Ellis Institute, an international mental health professional training institute. Enroll today at CIU.